Very excited today have Mr. Jonathan Bush here. Needs no introduction. Many of you know of Jonathan through his previous accomplishments. Actually, our present practice, Baker Health, uses Athena as our EHR, and that was the brainchild of the venerable gentleman sitting next to me now. But I'm more excited to talk about what you're doing now. It's really interesting at Zus, and also very excited to understand your view on all things healthcare. I want to get to the conversation, but I think while most people are, I'm sure, familiar with your background, you tackled and are tackling one of the most complicated aspects of healthcare, which is parenthetically miscommunication among doctors, doctor to patient, right, health system to health system. And so when guys like me talk about how messy healthcare is, the payment structure, like you have third-party payers, the customer doesn't pay you. Medical education is fraught with issues. In a massive problem that is healthcare, probably the most complicated one, and one that actually speaks to all the others, is the intercommunication railways, right? Because like when you talk about payment is not disjointed from the EMR, right? And people, I think, from the outside don't see, well, there's an EMR problem and there's an incentive problem. No, but if I want my shared savings to get paid, I have to document whatever. And the word document comes up in every aspect of healthcare. Yeah. And so you really don't sit at one of the fringes of healthcare. You have spent your career right at the nucleus of it all, which from the outside people might be like, well, the EMR is important, but no, but. It really sits at the front of things ever since, legislation moved EMR and mandates to the middle, which happened when I was in residency, like during Obama's time and beyond there. And so if we could just start, Jonathan, with, what made you, because you didn't grow up in healthcare, you're not a doctor, you come from more of a business background. First, what attracted you to go to healthcare, and then why you took on the EMR space to begin with?
Well, I was attracted to healthcare because I thought I wanted to be a doctor, until I learned how good a student you had to be a doctor, at which point I needed a plan B. But there was a guy in the White House Medical Corps who I really respected, and he was an adventure guy, and they would practice trauma surgeries all around the country and the world to be ready if the president got shot. And he said, look, try before you buy. You're not that good a student. You don't pay attention. Consider other things. But to try, he hooked me up with the New Orleans Health Department, which had 2 paramedics going on maternity leave. And so for $9.50 an hour, they let me. I had got the EMT certification and stuff, but that's how it started for me. And in fact, I concluded that whether or not I would have ever made it through medical school, there was a lot more opportunity to make things better with just as you described, that sort of the bloated, manual, confusing process connecting the doctor and the patient to the moment of care. And that connective tissue was a mess. And I thought, geez, I could take a dump on my desk and something would get better. This is a place where there's room for an amateur to make a difference. And so that's how it started for me. It was, and first I thought, well, why doesn't the ambulance treat if it's a chronic disease patient and they're just unstable, why are they driving them to the 4 hours of misery at the emergency room to get stabilized, and then what? They go home, with like 1 dose of their Preventil for their asthma, or, one little stabilizing thing on their diabetes, insulin or something. Like, this is all stuff that sits in an ambulance, right? So it started that way. And then it was maybe maternity care, because everybody gets treated like they're sick when they're pregnant, but you can be pregnant without being sick.
100%.
And so it was all of these ideas, all of which upped the ante on coordination. And so when I finally started Athena with a buddy of mine, we needed a lot of sophisticated coordination that you didn't need to just be a doctor treating, in that one-on-one relationship. And so we built AthenaNet. And I like what you said about the EMR, sort of the center. I believe that the EMR is the clinical center of the encounter, but I believe that center is moving right now. I believe that the center, the atomic unit of medicine, since the post-war World War II era, when the government let employers, pay for health care as a pre-tax expense to prevent wage inflation. That's how it all started. Can you believe that? That shift, I mean, that sort of gave birth to the idea that the atomic unit of all medicine was the claim. So the EMR is essentially the documentation, the supporting evidence of a claim.
Right.
And so when you look in an EMR, you see all of the reasons why, all the systems that you checked. This was normal, this wasn't, this was acute, upper left quadrant, whatever it was. But it's all related to that particular encounter, what that particular procedure was for that day. Not present in that EMR might have been something that happened the year before across town, or broke his arm in Vail or whatever. I believe that as payment shifts from the encounter to the life, the atomic unit will shift from the claim to the chart. And I believe that the chart will not be, it'll go from, if you think about it, your EMR is like your iTunes. It's like whatever songs you bought.
Yeah.
A longitudinal chart is like Spotify. It's every song ever sung by every singer. And you didn't buy them all. You subscribed to all of them, and you follow your nose as you need to, or as you're, in the case of music, as the spirit moves you. I see a Spotify medical record on the horizon as payment moves to the whole life. And I see guys like you who are really good at attaching to patients, building a bond, winning in that world, because that world will be about earning the right to navigate a patient. Trust me, you don't need back surgery yet.
Right.
70% of them are a bomb. Don't do it. If the health plan tells you that, you're like, hey, you're just trying to keep me away from the hospital for special surgery,
Right.
But if you've actually earned the right to navigate that patient, I say, all right, what do I do? Well, I've got this incredible person. They're going to help you with back exercises. You're going to do it every day. I've got a video. You're going to take it home. Whatever. You build a plan. There's no ROI. I mean, what you're doing now is just saying, hey, you need it. You know you need it. Pay me a subscription to get what the world should be doing for you.
Correct.
As payment moves to the whole life, and you've experienced this, there may be an ROI for doing that just just in order to earn the right to navigate. But once you're doing that, you're going to need to see what else is going on. And you're going to need to see it soon, as quickly as possible. At my company now, we're working on actually getting an echo on eligibility checks. So if a record is in Zus, we can get if I'm a patient of yours and you're on Zus, I can tell you, you can know that I'm about to see a cardiologist in 2 days.
Okay.
Because the cardiologist checks my eligibility to make sure I'm covered.
Okay.
And you find out. That's useful for a lot of things. One reason is you might not know that. You might not have the record. Now you're going to get the chart. You're going to get the ejection fraction from the cardiology visit. You're going to get all of the information without a fax, which is still today, it's amazing. Everybody's on an EMR. 50% of medical record exchanges of medical record information are on a fax.
Yeah.
I know no one who owns a fax anymore. So that's the first use case. Hey, I finally got the information cleanly integrated logically into my record, so I'm not going through playing Marco Polo with the ocean to find the records. But the second thing is I know 2 days before it happens. And if I've earned the right to navigate and they've bumped into some cardiologist at a golf game that is the wrong thing for them to do,
Right.
I have an opportunity to talk to them.
Right.
And say, hold on, you need a cardio, your Lipitor's off. I got you,
That's pretty incredible. And now that I'm listening to you and what you're doing at Zus, and I want to hear more about it. I know you're just kind of giving a high level.
That was, I couldn't help slip in a
No.
plug, but the migration of the center of gravity from the claim to the life, I think, is the big financial and clinical movement that we're going to see in the next 5 years.
And it makes sense, Jonathan, listening, because when we use Athena or CERN or Epic or whatever,
Yep.
it's the 1.0. And what you're
That's right.
describing is dragging that into the 2 or 3.0, which makes all the sense in the world as to where we need to go to do what's right by patients. The issue, of course, like many things in healthcare, is seeing the right thing that we on the inside know, and patients themselves know, isn't always permissible with all the regulations, incumbents, market capture, all the isolation, the silos of systems, because there's also a protectivism. People don't realize. They're like, well, my data is over there. Where I used to, a couple things.
Oh, I mean, the hospitals still think their EMR data is like precious.
Yeah.
Don't touch precious. I'm not sharing precious.
Yeah.
It's the ring to rule them all. I have more data than anyone.
That's right.
You have a blind man and the elephant just like everyone else. You only have the portion of the record that was when the patient was at, Mount Sinai.
Yeah, exactly. And where I used to work when I was at Optum, a couple of the things I learned that they do really well, and I was able to learn, is you talk about longitudinal care, and really the best version of a clinical manifestation today is full risk. So one of the things we did, my brother and I helped start what is still, I think today, this was a few years ago, the only full risk Medicare Advantage program in New Jersey. All right. And we learned that because, we're from the East Coast, where full risk is like 9 out of 10 doctors, this is not an exaggeration, in 2025, 9 out of 10 doctors in New Jersey, New York, Connecticut, if you say full risk, they think it's like how you play poker. Yeah. They really have zero.
All in.
Yeah, they have zero sense of what you're talking about. Now,
No.
you go to California, 50% of the docs they play that game, and it's kind of odd how in the same country, we all went to the same med schools and stuff. It's a completely different paradigm, and it really does influence how you practice. In many ways, it can influence how you practice, and so the thing is, and this is more of a question, I think, given your background, we've been at the proverbial cutting edge, or at the edge of going to risk, of having value-based care now for decades.
Right.
Like when I was coming out of training, this is like 16, 17 years ago, I heard whispers. Then like halfway through my career, it was like, oh no, full risk, value-based care, and every acronym, ACO, MC, came out. And if I'm gonna be honest, and again, I've done full risk, and I've done fee-for-service, and I've kind of done everything in between. Today, still, our healthcare system is defined by fee-for-service.
For sure.
And so
today, the optimal, the peak performance of risk is really just about risk adjustment, which is basically taking the claim file and seeing if maybe this person has some diseases that didn't get counted in their risk profile, and that you can get more money. It's just another form of fee-for-service coding, whole life coding.
Yeah.
There's also the quality measure game, so in a risk contract. These are all conditions that needed to be met to enter risk. It's like, hey, I'll go into risk, but if I have a super sick population, I want more money than if I have nothing but vegan mountain bikers, right? Or Pelotoners, because the mountain bikers might break their shoulder. So the government and the payers, okay, fine, we'll do risk adjustment, right? And then the game became completely about that. Now, partly because it's easier, and it was undone, so there was lots of sort of unplowed soil to make easy money on, but also because the atomic unit is still the encounter. You can't really control much outside of that in a fee-for-service mindset, technology stack, business model. So it's like, well, I can still be my fee-for-service self, but get paid for full risk by doing this coding and this, having a team call for mammograms, make sure everybody gets their mammogram or whatever, or their colonoscopy. Soon, I believe somebody's going to go, shit, let's try to, and it's been done in California. There are billionaires in California, primary care doctors, who got into the business of bringing fruit baskets to nurses in the emergency room and saying, listen, this is my cell. If any of these people come in here, please call me.
That's right.
And they race in, and they say, oh my goodness, why are you here? I'm so sorry. I'm like, what a great primary care doctor I have. And of course they're saying, I'm going to stop this admission if it's not necessary. And they made great fortunes. And that's available, still undone.
And better care.
And massively better care, better outcomes, everything. I mean, as the business is scaled up, there was, accusations of, holding back on care,
Yeah.
et cetera. And part of this is holding back. It's like, Jesus, you don't need that.
Right.
You know, I was so proud of the orthopod who, I have a broken bone in my shoulder right now.
Sorry to hear that.
It's okay. It's trying to pretend I'm not 56 on the ski hill. But, you know, I knew it was broken. You can see it on the film. And he's, look, I have every right to tell you I can put screws in it and stabilize it. But honestly, I would only move it 1 millimeter. And you're 56, and it's going to heal. So just get a little arthritis and don't go through surgery. And he said, by the way, the data is now that you'll probably get the arthritis anyway from the wound. So I was like, you just gave up $40,000.
Yeah.
I gave him a hug. And he wasn't in a, you know, it turns out my plan, I'm on Firefly. So my wife is the CEO. I just saved $40,000. I want to say, honey, what are you going to do for me? I just got you $40,000.
That's 2 hugs. Yeah, isn't it interesting, that story? Like, people sometimes think the best doctors are the ones who do stuff for them.
Sure.
And I tell them, when the doctor...
primary care, right?
Yeah.
I mean, there's no primary care doctor today who doesn't know that there's an unspoken mandate that somebody gets a prescription
Exactly.
before they leave.
Yeah.
And in the world before pop health tools, it's a good way to make sure the patient comes back.
Yeah.
Oh, your prescription's expired. Come on in. Let's check.
Yeah. And I always tell people, when you go see a doctor and you leave with nothing, that's your doctor.
Yeah.
People are like, well, I went to him. Why am I going to pay a $30 copay and you're just going to tell me this? I'm like, the telling is the best health.
That's it.
Instead of the writing.
That's right. A lot of the primary care, and what do you think? A lot of the primary care, the technical, clinical stuff that happens, the wax paper that comes out and the Welch-Allen device to look in your ear, is really trust-earning theater in terms of its actual clinical significance.
Yeah.
An EMT making $20 an hour can do 90%.
Yeah.
That can do a pap smear, can do all those things. It's the doing of that and the getting to know the person that is, it's theater of trust building. And what's interesting today is to watch some of these newer companies try to replicate that over an app.
Yeah.
Because the fixed cost of that room and everything else is exhausting. And you don't get as many touches. Right? You could have a banger of a 10-minute visit and really go a long way to build trust with that patient. But you can only do it so many times with that patient.
Yep.
Whereas if you give up the 10-minute visit and you have, 20, 30-second text exchange, hey, it's acting up, I'm at a red light, I just reached up to pay the, toe in it, it stung, it twanged, tell you, doctor writes back, okay, that'll happen, try this exercise or whatever. That continuous stream of touches in a fee-for-service world, you just gave up a visit, you just went upside down for no reason, and you're supposed to be seeing a visit, not responding to a text.
Right.
Problem.
Right.
But in a whole life risk world, you just made money.
Why your insight is so keen and so on the money. Why?
I think you know these things. I'm not giving you this.
They are, but
You've gone up this mountain way higher than me.
But I'll be honest with you, but I rarely come across people, even people who've spent a long time in healthcare and done great things, who still get it. Honestly, that's what's fascinating. I have a question.
The good news about healthcare is you can get a really good idea, and you can be very forward-leaning for like 20 years, because even though we know it, it takes 20 years to do it. It's like Star Wars 1 is coming out in movie theaters of healthcare like this week. Oh my God, Star Wars, who's R2-D2?
Jonathan, we have a chat in our app.
Yeah.
So our app has a lot of cool things. You could do virtual yoga classes for free as a member, okay?
Brilliant.
You could
Earning
book
the right
an
to
NAD
navigate.
infusion in the app. Mm-hmm. The thing that people love, we have content on mental health. We have board certified therapists in our app who can, you're depressed, text, virtual visit. Okay.
There you go.
The thing people love the most is the chat, which is they can text us and a doctor will text back in a minute saying, yeah, I can refill your Propecia, but you need to see you for your blood pressure or whatever. And only when I sit with non-healthcare friends, like when I sit with a finance guy or whatever, they're in awe of how something so simple.
Yeah.
Because Uber did that, whenever, ago, or DoorDash or whatever. Oh, and you're exactly right. It's molasses in healthcare. And so the frustrating elements of it, the bureaucracy, the regs, blah, 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 is also why an incremental move is so seismic.
Yep.
Right? And so I
That's
guess
right.
for a schlub like me who isn't that smart, it doesn't take much to differentiate, right? Which is good and bad.
It's great.
Right? In many
Yep.
ways. I have a question for you. Listening to you, you're taught, if I didn't know your background and I heard you, I'd be like, this really, really smart guy gets it all, and he's solving like all the infrastructure, gunky stuff, the communication and so on. Why have you never gone into or toyed with or addendumed the physician space, like the human capital element?
I have.
Oh, you have? Okay.
Well, Athenahealth was a physician practice management company. So we employed
Okay.
35 midwives,
Oh, I wasn't aware
8
of that. Okay.
OBGYNs. I mean, we'd employ, we had the physician practice management,
Okay, yeah.
20% whatever arrangement with. That's how the company started. And then as soon as I got fired, my wife and I both got involved with Firefly Health, which is a continuous, always on. It's, it's your model, but no offices, no beautiful, Four Seasons experience,
Yeah.
but no extra pay.
Right.
And it's just the average Firefly member talks to their care team, nurse practitioner, therapist, MD, just as you've described, 30 times a year.
That's great.
30 encounters. They never meet them.
Right.
They can do they can make an appointment for like a video visit.
Okay.
But all the pap smears and samples and throat cultures happen at a network of urgent cares called Firefly Nearby.
Okay.
And they arrange a sort of a flat fee
Okay.
to direct book you in, get you the procedure, and get you out.
That's great.
But yeah, no, I'm infatuated by the care experience. I'm infatuated by doctors. The ability to descend on a person and make such a profound change when it's not bullshit, when it's not cruft, et cetera. I mean, ambulance business, 90% of the calls, we called them cabulance calls. We're not critical. But then 10%, holy shit, I just saved this guy's life.
Yeah. Problem is you don't know which one is coming in.
Never know.
Right.
Never know. Because the smart schmucks know to say chest pains.
Yeah.
And then the ambulance is there in 2 seconds and it's like, oh, it's
I
George.
want to, if it's okay, Jonathan, I want to get back.
Yeah, sorry.
No, not at all. I want to get back into the clinical stuff in a minute, but I don't want to forget to ask you something because the energy that I'm feeling from you makes me want to ask it now.
Okay.
Healthcare entrepreneurship.
Feeling any energy? This is great.
Healthcare entrepreneurship is a phrase that's overused.
Yeah.
Just entrepreneurship is overused. Healthcare entrepreneurship, I find, I get labeled, like you get thrown around, it's almost icky. It used to be a compliment, it's almost icky. But someone who's done what you've done, and as I listen to you, someone who has that ongoing vision, like you've climbed the mountain several times and you're still just as hungry. You're acting as if you're at the foot of it, which is, if you ask me what's the number one trait of an entrepreneur, is that the mountain has never been climbed. And
That's right.
that'll define your success. even if you
Identify an unmet need that no one knew they had.
Yeah, and there's some elements of risk tolerance that I think are really underrated. People talk about it, they write it in the business books, but until you're there and you're facing it, like, well, this makes no financial sense. Screw it, we have to do it. This is what we decided we're going to do.
Yep.
Having those moments, which from afar, people are like, yeah, I can do it, and very few can.
Yep.
Picking the right people to go to war with, and it is war, right? These kinds of things. Can we step out of can you, if you don't mind, because we do have a lot of people who watch who aren't in healthcare, but they come from varied backgrounds and they might be at a point where they want to do something entrepreneurial. Can you talk a little bit about some of the maybe the highlights of your entrepreneurial journey, good or bad or indifferent, that might be good lessons?
Well, I think you encapsulated, I think, just a second ago, what I think of as the most important joy of entrepreneurship, which is this setting out with people you love on nearly impossible missions.
Yeah.
I prefer to have them be noble in some way. To imagine business success somehow relating to some kind of social good.
100%.
I think in medicine, where so much of the dollars are being paid have been taken by force by the government and are coming in, you have to be, I think it's more satisfying to be conscientious about it. But I think that's setting out, and like you say, especially when you set out, nothing is working. Like everything, you lose with Zeus, my current company, I mean, we had a negative gross margin in the hundreds of percents. Like, you'd get paid $1.50 to monitor one patient for the month, and we'd spend $4 doing it.
Right.
And little by little, we figured out how to get scale and be more efficient. And wait a minute, that document's the same as that document. We don't need to pull them both. And,
Right.
now we've got a little gross margin, and we've got through that sort of neck of the woods.
Yeah.
But it's that comfort with sitting
Yeah.
in what looks like a nosedive
Yep.
for longer than most people want to sit in a nosedive with people you love. I
Yeah.
think I like that you mentioned that.
Yeah.
And that mindset is not for everyone,
Yeah.
and it often ends in a lawn dart, like the nosedive hits the
Yeah.
the earth. But when they don't, when they pull up, they're extraordinary, and they're in a space that no one knew was there.
Yeah.
And that's really, really exciting.
Can we talk now about Zus?
Sure.
Can you, because you've mentioned it a couple times, but it's not a straight shot. Like, it's not one of those things
No.
like, hey, it's an urgent care. It's kind of brilliant in that it's trying to take on this complicated part of healthcare, but that makes it complicated even just to understand. Can you take a few minutes, if you don't mind, Jonathan, and just explain what Zus is and the problem you're solving?
Sure. Zus is, for the healthcare geeks, Zus is an always on, meaning it's constantly updating itself, fire native, meaning it's all structured so that a machine could read it, API first, meaning it could be inside any piece of software that you may already have, the internet, longitudinal, meaning it's your whole life, medical record. That's what it is. It's just the stem cell of the future whole life-based business and clinical model.
Okay.
Athenahealth was a wonderful system, but its medical record was built under duress, under the High-Tech Act. Remember, there was $50 billion you would get if you were one of the, and really, if you didn't get to be one of the ones that got the reimbursement, you probably missed the boat, and the doctor wouldn't say, oh, now I'll switch to a better one.
Right.
Once they've gone from paper to an EMR,
Right.
it's a long lift to get them to go to a different EMR,
Right.
at least at the time it was. So we built our medical record to support the claim, to be an encounter-based medical record, as are all medical records that were installed during that period. What we're doing now is establishing Zus as a sub-basement beneath whatever front-end medical record you may have that shows the whole picture. And in most cases, you can turn on a setting in your front-end medical record and see the whole record right there on the screen with it. So in your phone, you've got missed calls or all calls, and like if you have all calls, it's black and red, and the missed ones are red, and in your EMR, you can have just what I typed or the whole chart. And when you click the whole chart, you're seeing everything that Zus pulled, logically integrated. If you got a lab result from your lab and a lab result from Quest and a lab result from LabCorp, and it's all the same test, you'll see the analytes graphed as one line, not 4 different attachments to go look at.
Who's the present client now? Is it a health system? Is it a private practice? Is it all of the above?
So we started with, I would say, the most tech savvy, sort of the maven class of the risk-bearing care providers. Most of these are venture-backed companies. They have, a chief product officer. They have their own software engineers in the company. They have risk contracts. Most of them have a very large digital component to their service design. So there's televisits or messaging or, remote, and that they drop into, their patients drop into lots of different locations of care. And so pulling together the whole picture is particularly valuable to them. Now, I believe once you're really trying to win at risk, everybody will need that. But the first wave were people with a lot of technical self-sufficiency. Now we've just got enough of the front ends built and enough of the EMRs already pre-integrated where more of the I wouldn't call them mainstream, but leading edge traditional practices can say, oh, I can turn that on in my Athenahealth and use it and do better on my contracts.
Okay. And something that comes to mind, I'm sure you've thought of this, but I just want to ask the question. To me, the stakeholder in healthcare who we're so jaded in healthcare by the misaligned incentives, meaning it's an unfortunate reality, and anybody who doesn't admit this is lying, but it's an unfortunate reality that I want to take care of Jonathan. I'm a doctor or whoever. I want to take care of Jonathan. But before I think of what's best for Jonathan, I'm like, what's Aetna or Cigna going to say about this? What's the employer benefits plan going to say about this? What does before I prescribe Jonathan whatever I might need to prescribe him, what's his PBM going to say about this? And actually, when I'm trying to help Jonathan, there's 17 other stakeholders who I have to account for, and all of a sudden what's best in the best interest of Jonathan goes to the end of the line. And what I just said happens almost subconsciously in doctors and healthcare providers, and it's almost embedded now. It's not even a conscious. So,
well, the very nature of a primary care office visit, that person is the person with enough health orientation and awareness to come to the doctor.
Yeah.
Right? Yeah. Probably the most expensive patient on your panel, if you were fully at risk, is somebody you've never met or you met once at intake. And they're allergic to their couch and they're going to the emergency room every third day and they don't know why. And when they get back from the emergency room, geez, I'm tired, maybe I'll go lie on my couch. The folks that drive most of the changeable cost aren't in care very often, aren't in primary care very often.
Right.
So I agree that, but in a visit-based world, you're not equipped to go find the guy who didn't want your care and convince him.
When I hear what you're doing at Zus, I think that the stakeholder that's going to be most incentivized to want this now is the patient themselves. Meaning, what you just laid out, if I'm in a value-based care place and I'm beating the MLR by whatever, I'm like, that's cool, tell me more about it. If I'm an insurance company and I'm like, well, are my providers in my network to decrease costs, let me know more about it. We have our own tools. But if you go to a John Smith out there, you're like, hey, you know how when you go to this ER in the past 5 years...
Give you the clipboard or whatever.
Correct. Yeah. But how about if you had something that you owned your own individual health record?
Yeah.
Right? How about if I gave you that? I think they'd be like, where do I get that? Because every time I go to the cardiologist, he asks me what the ENT said, and then I'm on the phone with my primary. They use 3 different EMRs. They don't ever talk to each other. Yeah. And I feel like I'm being punished because once I went to Quest instead of LabCorp, they can't track down. I swear to God, my LDL was what I told them, but my doctor's system doesn't have it. Right. So do you envision a world, or maybe you're already doing this, where I don't want to use the word selling, but this is being value propped directly to the patient?
Yeah. It's funny how history works. Like, that should be how this was born, was a consumer movement. The reality is, going all the way back to the beginning of our conversations about some of the providers not really wanting to share their data, bigger systems that have a data business, don't want someone to just get the data for free out of their data business. Today, there's no punishment for a hospital or any provider refusing to share data electronically with a consumer. There is a legal, first there was a problem where the hospital's like, I can't because I don't know the consumer's the consumer. So then regulators came up with a definition of how you can prove you're you, a little bit like CLEAR at the airport. Okay. It's called the individual access service. So if you build an individual access service where you take a picture of yourself, take a picture of your driver's license, you answer some questions about what car you had and didn't have, and they say, oh no, he knows, that's him. So that's been solved, but there's still no punishment for not responding. If a doctor asks another health system for their electronic records, there is a punishment if you don't respond. And the doctor's gonna be like, I'm taking care of this patient, what's your problem? And you know who they are, they have a national provider identification number, et cetera, they're on an EMR. So if the individual access service channel ever loosens up and opens, I think we're in for a big, big transformation. Okay. Your Oura Ring does a lot of correlating data just on the few vitals that it gets. Right. No other knowledge, your birthday, they don't know anything. Right. If they had your whole phenotypical profile, what drugs you were on, when you take them, whether you split the pills, wow, the insight And that a provider could, imagine have a screen that says, hey, here's my 5,000 patients, and I know 3 days before they get sick, that they're going to get sick.
If I'm a doctor watching or listening to this, or an executive at a hospital system, or an entrepreneur building out something to take on risk and kind of disrupt or innovate around care delivery, how do I get Zus? Like, I contact Zus, and what happens? Do you bolt onto the EMR, or
Yeah,
is
it's actually just a setting. You just turn it on
Okay.
in your EMR.
So it's a pure software play.
It's pure platform. It's not, there are screens that you can look at directly on the Zus
Okay.
site, but almost all of our customers are looking at Zus through Athenanet, Canvas, Healthy, Elation,
Okay.
eClinicalWorks, Snowflake, Salesforce. All of these platforms have a Zus setting in them.
I see.
And so you turn it on, and now you're seeing the whole chart. And you have a population profile that's saying this many people are out of whack on their quality measures, this many people are missing risk adjustment diagnosis, this many people are rising risk, they're going to be
Right.
your spenders in the next 30 days. That is all data that is coming from Zus, compute, analytics, but it's visible in whatever systems you've already got.
Got it. Got it. That's awesome. That's really cool. That could really save lives.
Well, I think it'll save lives. I think it'll save money. And it's, having done the baton death march of EMR implementation for 20 years, I love the idea that it's just like, we'll give you a training class, but here's the screens,
Yeah.
So our implementation total time is always under 30 days.
That's
And it's
amazing.
mostly just when they're free to meet with us to,
That's awesome.
get 10 minutes of training.
That's awesome. I want to be respectful of your time, and I feel like I could talk to you forever.
I love the idea that I might have other things to do.
But I want to, it's related, right? We're talking about technology, and we're talking about how technology can be leveraged to improve the healthcare experience. Everyone and their mother, you meet with a lot of folks, investors and stuff, and we're always dealing with folks that we've dealt with that invest, and they're looking for the next big thing. And I cannot remember the last time in the last 24 months I sat with somebody from the outside who doesn't ask me, well, how are you leveraging AI, right?
Yeah.
And it's getting to the point now where, I talked to one computer science guy from Berkeley, and he tells me, listen, wait, because don't jump into the AI thing because it's getting hyper commoditized and blah, blah, blah. And you're gonna need one software engineer to do what, 3, and then the next guy tells me you don't need any software engineers now. You can just think of it and type in whatever, and Gronk 3 point, blah, 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 blah. What have you thought about where AI can help? What's your perspective on AI?
AI is a superpower for Zus in 2 areas. So the Zus factory, if you go sort of behind the scenes at Zus, there's 3 things that Zus is doing. One, we nickname fresh making. So we're looking for evidence that a patient has been somewhere, like following the breadcrumbs. So we go through the prescription feeds at SureScripts, and we say, oh, look, here's a prescription from Dr. Schwartz from the day before yesterday. Probably today, there'll be a chart. If we go ping Dr. Schwartz's EMR, there's probably a note that was left, some sort of encounter that resulted in that prescription. So now we get that chart, and we can add it to the Zus record, to the aggregated profile. Okay. So there's a lot of fresh making. The second thing we're doing is sense making. When you get that data, it's from that guy's EMR, which is structured one way, which is different from another guy's EMR. Sure. And this guy always just puts, regardless of the structure, puts all his findings in his little note tab because that's where he remembers it for next time. Everybody's got their own way of organizing their life. Yep. And so the AI comes in. When we get these data, they're all over the place. We can assign AI agents to read it all and say, that's, here in the note, the cardiologist is talking about ejection fraction. And here's another mention of ejection, and there's another, and here are the dates when those notes. So now we can make a graph of the patient's ejection fraction over time, right? And that's a fire record. If you happen to have like a bespoke cardiology EMR, there might have been like a little graphing function you could type it in. But people are busy. Doctors are just, give me the dictation, let me get out of here so I can go to the next thing. So AI allows us to go through other people's trash and turn it into a logical, consistent data model.
So cool.
And the second thing we do is when you get a whole chart, it's a lot. Yeah. It's 6.5 years of history. It's 1,000 fire, 2,000 fire resources. what do we need here? Okay, this is a primary care visit, it's a first visit, the complaint is chest pain. Organize this chart optimally for that discussion.
Right.
And up comes kind of a third-year resident's description of the patient
Right.
off of that record.
Okay.
So the lens, it's the same record underneath, but the lens that looks at it and focuses on it focuses differently by use case, by persona. I'm a navigator that works for the doctor. I'm the referrals helper. I'm a social worker. I'm a clinical. I'm the therapist in your practice.
Right.
Different, a whole bunch of detail on a patient's musculoskeletal history, maybe not so important for the therapist. But that they've broken 4 bones might be, that might be this much of the screen. Whereas if you're an orthopod, that might be the whole screen, and their heart disease medications might be tiny. So the second big AI use case at Zus is chart summarization for different use cases.
Yeah, it's a mess when you try to put this together. You're right. I didn't think of that. Like, one thing is, we do something where we're able to get the different disparate EMR histories. That's cool. That's its own mountain. But then when you do get them, that you're like, oh crap, now I have to.
It's literally like getting, it's the digital equivalent of getting a trash bag full of like pizza menus, like placemats, and vital medical information in the trash bag.
Right.
And so you're like, okay, that's a pizza menu, that's no good. Oh, that's the same as this one, that's a duplicate,
Right.
And that process of going through the trash and making it make sense, uncrinkling the good stuff,
right.
And then reading it, that is a really great AI use case. And without it, nobody really wants to see these charts.
Right.
To spend 3 times as much time, especially since there's still a lot of fee-for-service energy. Like, if I see something that I could have done, I now probably can't do it, I don't know how often that goes on, but it's not never.
Yeah.
So now if you can get right to it and get the whole summary, you'll find something useful to do with your time. You still have a great business. But to go backwards in order to see it all, I don't think anybody, that's not a great product.
Right.
So Zus works very hard in these 3 stations. The third station is we then do the work, summarize, but we might also analyze. We might say, look, I only care about patients that have missing quality measures, that are responsive enough that if I called them, they might actually fill those quality measures.
Summarize and analyze. That's like nirvana.
That's it.
My last question, Jonathan, and I want to thank you for this time. This has been great, and I hope we can do it again. And I know you're like laser focused on Zus, and we're laser focused on Baker Health, and if you're trying to change the world doing something, that's not a full-time, that's 17 full-time jobs, and you're not looking elsewhere. So with respect to that fact and reality that we both live in, where is, and it could be you personally or just at a high level, where are folks not looking that they should be looking to make major differences in healthcare? Like what you just talked about is something that's logical once you hear it, but nobody was thinking of. And when you come out of this, it's going to save lives and save money. What are some other areas or perpendicularities in healthcare that, let's say, the guy or gal who's like 25 years old wants to make a huge difference and set out?
I think, and this is like, you better be 25 and you better pack a lunch. But if we move to a longitudinal shared record, whether it's Zus or a competitor of Zus or 5 competitors, Visa, MasterCard, and Discover, all fighting to be the record,
Sure.
That has serious implications for payment. What's a claim? It's like, I claim that this shit is in my chart.
Yeah.
And you read it and say, oh, I believe you, or I don't believe you, or show me more, and you send then additional documentation necessary, ADN, and the fax goes across. And there are 2 standing armies of billers and adjudicators out in the world bonking into each other like blind man's buff. And if both the payer and the biller are looking at the same chart, why is there a claim? Why couldn't you just say, don't just, my webhooks will know when one of my members is in your office. We'll read the note and we'll agree on some simpler fee schedule than all these ridiculous codes, and you'll just invent your own bundle, a regular visit, a serious first visit, a whatever, fixed visit, you can make it up. And then as soon as you're finished your note, the Venmo ledger just says, yo, at the end of this month, there's an extra $200 or $600 or $20 or whatever. And it's just ticking, ticking, ticking all day long. And at the end of the month, whoosh, wire goes out. And there's no more billing.
Okay.
I see that coming.
So remittance 2.0 or some version.
And think about in your business, like, let's say you get up to a lot of lives. Maybe you want to go deep now. Like what you used to do is maybe hire your own cardiologist, et cetera, or specialists. But what if you said, no, I'm not. I'm going to just build my own network. I'm going to be the payer. You're not going to stand up a United Health claims adjudication. But if for your own network, you could actually just have a passive accounting system running in the background, even if they're on different EMRs or anything else, when one of your members shows up, that medical record data is dropping down onto a common record. You could set hooks and say, hey, when you join my network, there's no billing. There's no pre-cert. I see it when you see it. You're paid. That's not that long a technical putt from having a common record. So if the common record movement, which has Zus and other competitors trying to win at it, and you could be another competitor in that, but that would make it harder for me, so please don't do that. And it's been going for a while now. But the job's to do, like, nobody's thinking you could have claimless payment at small scale. But if you think about it, if risk works, everybody who's really wanting to win at risk is not just going to keep doing upcode or risk adjustment. They're going to want to get into controlling the referrals, controlling the spend for the referrals. And if you could actually control payment without having to stand up a United Health claim shop, you could win at that. And it's not that long a technical putt from having a common record, a common version of truth that's in near real time, to having a financial measure on top of it.
That's fascinating.
Right?
That's right.
I think that's the next, that's the 2035 mega IPO, in healthcare tech will be the company that crushes claimless payment.
All right. Let me know when you want to get started on this so we can do it.
Well, I think you need a common record to do it.
Yeah.
And you need doctors who are ready to take on building their own networks, which means building up a primary care base and contract arrangements. So I think the two of us are already working on it right now.
Hey, this was a lot of fun.
Same here.
I really, really enjoyed it. I'm glad I got to meet somebody that from afar I've been admiring for a long time.
Oh,
really.
Thank you for saying
You're a hell of a guy. You've taken on giants and slayed them in the healthcare world.
Also been slayed by the occasional giant.
Yeah, but very few people have scalps to show, and you've done a hell of a job, and I'm a big admirer. So thank you for taking the
You're
time.
very nice.
I appreciate
Thank you
it.
guys.
Really
Thank
do.
you guys. Thank you guys.
Thank you, Jonathan.
See ya.
Appreciate it.